You're listening to Medscape's In Discussion series on multiple sclerosis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Ann Cross. Dr. Cross is a professor of neurology and holds the Manny and Rosalind Rosenthal, Dr. John Trotter MS Chair in Neuroimmunology at Washington University and Barnes-Jewish Hospital in St. Louis, Missouri. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I am Dr. Ann Cross, and welcome to Medscape's In Discussion series on multiple sclerosis. Today we'll be discussing cognitive dysfunction in multiple sclerosis. And let me introduce my guest and good friend, Dr. Lauren Krupp, MD. Dr. Krupp is a professor of neurology at New York University Grossman School of Medicine, and she directs the Multiple Sclerosis Comprehensive Care Center at NYU Langone Health. So welcome to In Discussion. And as I often do with guests, I'd like to ask Dr. Krupp, what is it that brought you to work on multiple sclerosis? Can you give us a little background on yourself?
Sure. Well, it's really a real pleasure to be here today. And I found multiple sclerosis really fascinating because of the immunology. I thought immunology was really interesting and challenging and complicated, but I'm also very interested in the brain and the mind and behavior and thinking. And although there are a variety of neuroimmune disorders that affect the nervous system, multiple sclerosis was the perfect marriage between neuroimmune processes and the central nervous system. Of course, there was not a whole lot that we could do to intervene when I first started in MS, but it's really dramatically changed in so many wonderful ways that it's been a very exciting time to live through.
So Dr. Krupp is an expert on cognitive dysfunction in MS. And so I guess let's start off by asking her, what do you mean when you say cognitive impairment in the MS population?
Right. So cognitive impairment is a term that, people often use somewhat loosely when a person comes complaining of brain fog or challenges with concentration and attention. The conclusion sometimes is, they have cognitive impairment. But in fact, cognitive impairment specifically refers to a deviation from normal performance on neuropsychological tests. And different authors will use different criteria, but it's typically a deviation from normal functioning on more than one domain. And in MS, the areas that are most commonly affected include cognitive processing speed, visual and verbal memory, to a lesser degree, verbal fluency, not a big issue there, but sometimes problems with visual spatial is a problem for many people, and, planning and executive functioning.
So how common is cognitive dysfunction, and what effects does it have on the day-to-day life of our patients?
Well, it's common. I think that it's more common in individuals who have had a longer disease duration and a more progressive form of MS. So in looking at the overall population of people with MS, the range of impairments that people give as a frequency are anywhere from 50 to 75%. If you look at people early in their MS and early in relapsing remitting MS, the frequency is much less. But for people with secondary progressive MS, for example, the frequency is on the higher end of that. And, the challenges people have can be pretty dramatic. I recall a patient who just kept on forgetting to pick up her daughter from daycare because she couldn't remember, that this was one of her responsibilities. So the effects of dysfunction in these different cognitive domains can be very dramatic. They can include problems at work, problems dealing with multitasking at the home, and problems with interacting with one's spouse or significant other.
Yeah, this is what I'm running into a lot in patients too. I'm wondering, in the busy clinic, I'm always challenged with how to ferret out cognitive problems in our patients when they're there and we don't have too much time with them and we're dealing with a bunch of other things too.
Right.
How do you screen for cognitive dysfunction in your clinic?
There's no great solution to this challenge of how to screen because nobody has the time to do the full assessments that are probably necessary to truly screen for cognitive difficulties. There is a brief international cognitive assessment in MS set of measures that's called BICAMS. And the 3 cognitive tests that involves is verbal memory, visual memory, and cognitive processing speed. But it takes about, a good 20 minutes or more to administer all that. And most people don't have the time or staff to do it. So we tend to just rely on the symbol digit modality test. And, that's very much a screen. And there are people who don't do well on that, who are not cognitively impaired. And the performance can be affected by how hard you're trying or how easily you're distracted. But it is sensitive in most cases. And we sometimes use that plus the sense that I'm getting on the exam and also what we're hearing from the family. So where it's difficult to rely exclusively on a patient's report, because when people complain of trouble finding their car or trouble remembering names, those complaints correlate with symptoms of mood more than actual cognitive performance. But if the spouse is saying, I'm noticing that my wife is getting lost when she's driving or is having difficulties in the kitchen, that's something that has a lot more correlation with impaired performance on neuropsych testing.
So what about mood? How often would depression, if ever, masquerade as cognitive dysfunction in the clinic?
As an example, I can say when I can't find where I park my car, I'm an absent-minded professor. Of course I can't remember such inconsequential things. And that's if I'm feeling good about myself. But if I'm feeling very anxious and worried about myself, oh my God, I have Alzheimer's disease. I better, get myself to a neuropsychologist. So the symptoms that people report don't always reflect cognitive deficit. And so a lot of symptoms of not remembering things, feeling brain fog and whatnot may reflect a mood issue without there being significant deficits on testing. And sometimes the neuropsych testing can be very reassuring. On the other hand, a severe depressed person, for whatever, in the presence of MS or not, can have pseudodementia and be withdrawn and not communicative and appear to be very cognitively impaired. And the degree to which that individual will do poorly on neuropsych testing, I think, is variable. And sometimes what you actually find is this variability in performance where they do worse on some of the easy tests and better on some of the hard tests. So it happens. Mood problems, fatigue, cognitive challenges, they blend together. And in people with more advanced disease, they've got all the problems. And sometimes it's easier actually to treat the mood issues than it is to treat anything else. And I always try to start with that before going to fatigue issues or even cognitive problems if there's a big mood component.
So speaking of fatigue, you also have written extensively on that topic. And as an aside, I'm just wondering, what are you doing these days in terms of assessing fatigue when people complain of that and dealing with it, treating it?
So when we saw interferon beta 1A injections being used the day after, there would be cytokine changes and fatigue and flu-like symptoms. So we know there's an immune basis to the problem. There's also a lot of correlations with, brain volume changes and white matter changes. But what we have learned is that pharmacologic management really doesn't work. So I emphasize things like exercise, mindfulness, a healthy diet, and a lot of what fatigue is, or some part of what it is feeling out of control. So you sort of feel overwhelmed, out of control, don't know why you can't do this or that, because in the sense of having no energy. And so the trick is to help the person feel in control. Either organize their day in such a way that the most demanding tasks are in the morning so they can manage the afternoon with less stress. There's a lot of just very practical energy conservation techniques. And then amazingly, things like mindfulness, yoga, exercise, those things really help fatigue. But they require more discipline than, just taking a pill. So you have to motivate the person.
Yeah. Back to cognitive dysfunction. I'm just wondering, so if you do an SDMT in your clinic and it's abnormal, do you immediately send them for further testing, or do you repeat it? Or
I want to see it a few times because there's a certain amount of jumping around that can happen. And I also want to make sure if it's not myself who's administering the SDMT, I want to speak to the person who administered it to make sure that the person was engaged and trying. I mean, one of the reasons why the SDMT is so sensitive is that it's not only capturing cognitive processing speed. You basically what you do is you give the person a paper with symbols on it, and at the top of the page is a key giving a number to each symbol. And then you ask the person to, look at the piece of paper, follow the symbols with their hand, with their finger, and read out the number that corresponds to that symbol. So to some extent, it's getting eye tracking, it's getting concentration, and it's getting the speed in which the person can go from looking at the key to looking at the symbol to giving you an answer. So it's actually getting multiple aspects of neurologic function. And if somebody's tried and did poorly and I see them again and it's still pretty poor, then I might then dive into it a little bit. But it also depends on, what's happening with them and how is this affecting or not affecting their interactions in the office or at home or socially. I mean, it's a tough one. It's not an easy thing to help people with because we don't have a medication that will turn it around. So what's required, if you in fact engage in neuropsych testing to confirm what you think is present, that is a problem with cognitive functioning, and you refer them to a neuropsychologist if you can, and you see that they have MS-associated impairments, what to do. So there's not a pill that will turn that around. There are a number of different options, right? And some of this can be borrowed from the Alzheimer's world. So there's the MIND diet, which is your healthy kind of avoiding saturated fats, raw fruits and vegetables, berries and things. That's one thing. There's exercise. And, the data is mixed to how much that enhances cognition, but it certainly improves quality of life. There are computer-assisted cognitive games that get harder the better you do. And those are really powerful for enhancing cognitive processing. And then in some places you can get a occupational therapist or even a neuropsychologist to do cognitive retraining with someone who, is motivated to do that and wants to really work on the problem.
I was just thinking that I personally have this battery of things that I go through that might be causing cognitive dysfunction or fatigue for that matter, such as, thyroid dysfunction and obstructive sleep apnea and all sorts of things do you have such a list of things that you sort of go through in your mind?
Sure. Sleep disruption is really critical. And one of the other things that people fall into is they often are using, benzodiazepines at night to help them sleep. And that's really not good for your cognition at all. So one big challenge is to try to come up with alternative ways to help people sleep that don't involve medicines that can be detrimental to cognitive functioning. So looking for treatable causes is always a good thing to do. Ruling out sleep apnea for sure is important. Unfortunately, you don't usually find low B12. The TFTs are usually unremarkable. They might be anemic, but that's not going to generally have that big an impact. There's a lot of biomarkers of cognitive impairment that are really linked to MS, and that includes brain volume loss, both in specific regions like the thalamus or the cortical gray matter or even the white matter, and also things like neurofilament. In a patient where there's a lot of brain volume loss, there's a good chance that the cognitive deficits are going to be from MS.
Yeah, I guess the horse is out of the barn at that point, right? Okay, well, you are also very involved in pediatric MS care. And I know you see lots of children with MS. Unfortunately, there are those kids. And could you tell us how cognition affects them or loss of cognition?
This is something where the history of MS treatment has really made a dramatic impact, as well as the history of understanding that kids rarely but can get MS. So it used to be that by the time we saw a kid who had MS, they were well into their disease with multiple relapses, significant delays in getting on therapy. And papers from the mid 2005 to 2010 described a lot of cognitive problems in these kids. But I'm really very happy to say that we've found that in the current treatment era, with kids also being diagnosed and managed much more quickly, that kids actually are doing pretty well. Kids recover from relapses incredibly well compared to adults. And they also appear to have overall better cognitive functioning, if you compare for disease duration. And the question is, what is it about youth? Do they remyelinate? Do they have ability to repair? Do they have better compensatory mechanisms that you might pick up on functional MRI? Because when we sort of think about what lies ahead in terms of challenges with MS, I think finding the fountain of youth as it can apply to reserve, resilience, and repair is really a critical question that lies before us. But I mean, I'm happy to say that I think that on the cognitive front, there may be some slowing here and there. But what I see more of is, kids sort of struggling with having a chronic disease when they should be, when they really want to be just like everybody else, and so it's more of a psychosocial kind of thing. But that was not always the case. That was not always the case.
Yeah. So things have improved, definitely.
Definitely, yeah.
So what are your hopes for the future for our field?
I would like to understand when I see a 65-year-old whose MRI shows a lot of white matter disease and they have MS and they're not on any therapy because they refused it and they're doing well. What is their secret? Because, they're not all triathlon runners, What is it that allows certain individuals to have this tremendous resilience? I mean, it's really a nervous system question. We've gotten very good at controlling the waves of inflammation in relapsing-remitting MS. But we don't understand when the damage has happened, when those, that demyelination has occurred and the neurons are flapping in the breeze without their myelin sheath, why is it that certain individuals can handle that so much better than others? And I think that's a lot of where we need to go. I think the other, of course, big challenge is progressive MS. And, I just don't have I think understanding, again, even in that disease, understanding repair is really critical. And coming up with ways of enhancing repair is important. So those are, I think, progressive disease and working on enhancing repair mechanisms. Those to me are the two big challenges. And I think we will get there. I mean, I think there's enough people working on it. I mean, after all, if you were a mouse, you'd have the problem licked, right? You get EAE and you do a little, remyelination and you're as good as gold, right? Running around with your tail wagging. So I think, the path is there. We just have a lot of work to do to forge forward.
Yeah. Well, I have certainly enjoyed this talk with you this morning, Dr. Krupp. And just to summarize some of the things we've discussed the frequency of cognitive dysfunction in MS, which is probably well over 50% in most people, but increases as they are older and longer living with the disease and getting into the secondary progressive MS phase. And we took a sidestep a little bit and discussed fatigue and its management because Dr. Krupp is an expert in that area. And we ended with a little discussion of pediatric MS and in particular cognitive dysfunction there and Dr. Krupp's hopes for the future. So thank you so much for joining me today, Dr. Lauren Krupp from NYU. And this is Dr. Ann Cross for In Discussion.
Thank you so much. This has been a real pleasure. Thank you for inviting me.
Thanks for listening to Medscape's In Discussion Multiple Sclerosis podcast series with our host, Dr. Ann Cross. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on multiple sclerosis.